Hello. Is there anyone from the IT section?
Yes, sir. Good afternoon.
Good afternoon. You have got my slides,
Yes, sir. Yes, sir.
so you will share. Yeah. Okay. No.
Okay,
Direct.
okay. Okay.
Okay. Yeah. Thank you.
Thank you, sir.
Good afternoon, sir.
Sir, good afternoon. How are you, sir?
I'm fine, sir. Thank you.
So you have just started this incredible program, sir.
Yeah, it is hit now. It is hit
Yes.
nowadays.
Sir. It has become all because of your vision and your leadership. You have been so humble to everybody that everybody is taken as a personal task, in fact. And all of, I think, personally, I feel getting involved in the API activity, especially the ICP activity of yours.
Sir, you are my first teacher when I started this PG classes when I was president. Can you
Oh, yeah,
remember?
yes. Yes, sir. Yes, sir.
Actually, I started this PG classes and
Yes.
you are the speaker, first speaker, I think. Anyway,
And
thanks.
how are you, sir? Otherwise, are we keeping good health?
It's okay. Going, it's all right, but I am getting old and old and old. That
It
is
doesn't matter. But your mind, your heart is young, and that's why you come up with so good ideas, sir. That is most important.
Thank you, sir. Thank you. Every day it is increased in number of in all classes.
Yes, sir, it will.
Class is becoming popular. Still, I'm getting lots of application every day.
Yes, sir, it is bound to come. The next class also I'll be taking. I will complete the XYZ of CBC. Today I've started with ABC, so I'll complete with XYZ of CBC.
Okay, so that is fine. That is
Yeah.
fine.
So that will complete the total complete topic would be
CBC, yeah,
yes.
it's a good idea.
I'm inviting other speakers also. I have talked to Dr. M.B. Agarwal and other hematologists also,
Yeah.
and I'll share the topics with them, and they will be also part of this program, sir.
It's focused on, because at least 20, I want 20 classes in each subject.
Yes, sir. We have already drawn the timetable. I'll share with you in a day or two.
Yeah.
Once I get the confirmation from the speakers, I will send you the topic as well as the speakers also,
That will be,
and the email address and the mobile number, so that you
that
can
will
also.
be easier for me. And what I want actually at the end of the class, I want to take an examination of each subject.
Yes, we'll prepare those questions also.
Yeah.
But the MCQs for the residents, PG students, and then we are also, as you suggested, we'll also to compile all these lectures into a book.
For a book, yeah. And
Yes.
then I have talked to one person, he will bear all the cost for printing and those things. So
Yes.
it will be okay, and the book will be in your name, and that will be inaugurated in next PCON.
Yes, sir.
Is my promise.
And also, I have written to you personally, sir, regarding as I want to bring a monograph on CBC.
Have you written or not? Talk
You
to
have
him.
written, you have written. I have written to Dr. Agam also,
Yeah.
because the headquarter also API headquarter.
Then,
Because there is no right now there is no book on the clinical interpretation of CBC in the country. So I just want to bring out the first book.
there is no problem, no problem. It will
Yes.
be okay. It will be okay. Actually, due to large number of students, I'm not able to see all the mails. That is a problem.
Yes, yes, I know, sir. I know.
Busy in these things. So it will be there in my mailbox.
Yeah, it is there. Yeah, yeah.
And you have got
Yes, sir.
you have got two lieutenants as well besides you. One is from your place. What is his name?
Daria, Dr. Daria.
Daria. Yeah. Where is he?
He must be joining, and Dr. Amit is there from your side, sir.
Yeah, he should be also there. I can't see him.
Actually, I just wanted to request you that in the next pamphlet, whatever that, please add their name as co-course directors. They are also part of my team.
That is in my mind.
Yes.
He has told me already.
Yeah.
So,
Because it is one person cannot do it. It is a teamwork.
I know.
I want to bring all of them in the limelight.
That's why I told two lieutenants.
Yes, yes, sir. Two lieutenants. But I will remain a soldier only, sir.
No, sir, you are the director. Your one lieutenant is here. I can see him.
Yes, Amit is there. Yes.
I can't see Darius up till now.
I'll call him and ask him to join. अरे तिवारी जी पूछ रहे हैं यार, आप ज्वाइन नहीं कर रहे हो? हाँ, तो good afternoon, Dr. Amit. How are you? You are just unmute yourself.
Yeah, I'm doing
Yeah,
good,
how
sir.
are you?
I'm doing good. I'm perfectly fine, sir. Good afternoon, Sanjay boss.
Good afternoon. Good afternoon, Professor Sudhir Mehta. I am Dr. Sanjay Kumar.
Good afternoon. How are you?
Fine, sir.
Do we have any timeline to start the class, sir?
Yeah, 2:30.
It's okay. It's
Good
almost
afternoon,
done.
sir.
Oh, Daria Sahab, very good afternoon.
Good afternoon.
Good afternoon, sir.
Good afternoon, sir.
I think the temperature in Jaipur is very high.
No. Today it rained also in the morning. It is around right now, it is 26 degrees Celsius.
Yeah.
Yesterday it was around 30 degrees Celsius at the same time.
Oh.
Just because of this rain, I think just because of something disturbance there in the Himalayas, I think that we had little rain in the morning.
Daria Sahab, कैसे हैं आप?
बस बढ़िया सर. All well.
All well. So, can we start this session?
Yeah, 2:30. We should start.
Yes.
Tiwari sir, please unmute. Tiwari sir,
Somebody
please
will
unmute.
share the slides.
Please unmute, sir.
Now unmute.
Good afternoon. Today's class of hematology and Dr. Sudhir Mehta, a renowned hematologist of the country, is going to take the class. But he has got two lieutenants besides him. One is Dr. Daria and another is Dr. Das. So I will ask Dr. Daria to say something before Dr. Sudhir Mehta starts his class.
Thank you so much, Tiwari sir, for giving me this opportunity. I think I can't say anything about Sudhir Mehta sir because we all know that he is a great teacher. He is a master teacher, and I would rather say teacher of the teacher. And I am with sir working last 15 years, and he is a mastermind of hematology. And I'm sure that all the students who have joined, and sir is very different. You can see the today's topic is ABC of CBC.
Dr.
sir
Daria,
will
one
start
thing,
from-
one thing I would like to say, one thing.
Yes, sir.
I started postgraduate classes when I was president of association. And Dr. Sudhir Mehta was first speaker of that class. So it is my privilege that he is again here with me. Thank
Yes, sir.
Sir, thank you so much for your great support.
Dr. Amit,
Sir, thank you very much, sir, for the opportunity given to me. And Dr. Sudhir Mehta, sir, is a now well-known international speaker. And this hematology class is going to take you from the basics of hematology to the nuances of hematology, where you can diagnose complicated diseases at the bedside by seeing small investigations which is often available across country at every smaller to smallest hospital, CBC. So let's begin the journey of nuances of hematology with a renowned and international faculty, Professor Sudhir Mehta sir. Welcome, Sudhir Mehta sir, to this class.
Thank you very much, Dr. Amit, for your kind words. A very good afternoon to all the attendees of this virtual class, which is being organized by the Indian College of Physicians, the academic wing of API, under the able leadership of Professor Kamlesh Tiwari ji. I am extremely thankful to Dr. Tiwari ji, Dr. Girish Mathur ji, Dr. Jyotirmay Paul, the president of API, and Dr. Agam Bora, the Honorary General Secretary of API, for including benign hematology in this short course certificate program of ICP. Now, till date, benign hematology has been an under-recognized and underappreciated entity in clinical practice. Today, I will begin the hematology class with ABC of CBC, and next week on the same day, Tuesday, I will complete ABC with XYZ of CBC. Now, hematology has advanced by leap and bounds in last 3 decades. Now, sophisticated investigations have moved from research to clinical labs. All of us as clinicians, they order CBC as the first and almost unavoidable test in our clinical practice. A PG student talks of CBC as a routine test, but does not give much importance to it. The cell counter printouts are seldom obtained by the clinicians, and it has never, in fact, attracted the clinicians at large. We, all of us, as in general, are just interested in few numerical parameters of CBC. But we forget about the other data like the illustrations like histograms, scatter plots, and so on. In fact, CBC contains a huge encrypted diagnostic information, which can help in the diagnosis of multitude of hematological diseases in the human body. Remember, eye sees only what the brain knows. Today, it will be my endeavor to give you the glimpse of wealth of information which is contained in the CBC. Now, what is the utility of performing this CBC? In fact, CBC is the basic hematology test in all specialties and subspecialties of medical and surgical branches. Okay. Half of our population, suffer from anemia. Nearly 15% of population in certain ethnic groups are carriers of thalassemia gene. Now the infectious diseases are acquiring epidemic proportions. Previously, we were seeing dengue and malaria. Now we are seeing scrub typhus, various types of viral disease, and recently we had encountered the pandemic of COVID-19. Platelet and platelet-related disorders are very commonly encountered in ICUs and in general wards. Next, I think. Yeah, next slide. I think I am not able to move the slides. Next slide, please. Okay. I will do. Okay. Now, this CBC, in fact, is the most frequently ordered test in clinical practice. And it is one of the most informative single investigations, which gives you a huge quantum of information. It expresses the health and disease state of the body. And the cell counters have traveled a long journey now with technological improvisation from simple uniparts cell counters to now multi-parameters automation. Can somebody help me how to move the slides? Yeah. Now, despite now we have cell counters which are stored even in district, sub-district, and rural hospitals, what has happened that there is no quality control over the cell counter reports because there is absence of national standards, there is no licensing or accreditation policies there, and therefore the quality of the CBC reports were generated, especially in the district and sub-district rural areas, or of inferior quality. And therefore, there is now a need that we should have some national policy so that quality reports can be generated. Now, today I have divided my lecture into 3 parts. First, I will just delineate the components of CBC printout. which usually consists of the numerical data, histograms, scatter plots, and the alerts of flags. Then I'll talk about the basic understanding of RDW and histograms. Now I'll show you in one of the slides that even at the periphery in rural areas, the cell counter printout, which is given to the patient, it depicts RDW values as well as the histograms related to RBC, WBC, and platelets. And therefore, now it is very important that even physicians in rural areas can make a provisional diagnosis of hematological disease, especially anemia, at bedside using this small printout of the cell counter. And finally, then I'll illustrate how CBC is useful in the interpretation in clinical practice. Next slide, please. Now, we are all aware of the what the basic CBC includes, the parameters which are measured directly by the cell counter like hemoglobin, MCV, RBC, platelet, and WBC count, and the parameters which are derived by equations like MCH, MCHC, hematocrit, RDW, and so on. I'll not talk about these RBC or the other hematological indices which we are all familiar with. Next slide, please. Now, this is a printout from a cell counter. I think this was an advanced hematology lab I had established 16 or 17 years back at SMS Medical College, and it was the most advanced machine at that time. Now, you can see on the left of the slide, there are nearly 33 numerical parameters related to RBCs, WBCs, platelets, and the reticulocytes. On the right, you can see the histograms, RBC and the platelet histogram. You have the scatter plots related to the WBCs and platelets. And at the bottom of the printout, what you can see is the messages of flags. These are basically the interpretation of the cell counter whenever they see any abnormality in the blood sample. Next slide, please. Now, this is a cell counter which is generated at the peripheral level. This was probably one of the small town in Rajasthan. A patient brought this sort of printout from for my consultation. And now you can see, we know all these parameters are all obvious to all of us, but there are two important parameters, RDW-SD and RDW-CV. And on the right of the slide, you can see the histograms related to WBCs, RBCs, and platelets. Now, we will utilize this basic CBC report today for clinical interpretation of disease at bedside. Next slide, please. Now, what are the normal values actually? There are no values for the hematological parameters. Like all other in branch of medicine and biochemistry, it all vary by age, sex, race, and demography. And usually the reference range are established by the laboratory, which is looking after a particular population. But in general, whatever the reference range which we are using in clinical practice are supplied by the manufacturers. Next slide, please. Now, coming to the basics of CBC, what a doctor should know for interpretation of results. Next slide, please. Now, red cell distribution width. I have told you that this parameter is now available in a cell counter printout, even at the rural areas in district and sub-district level. So it's very important that we should know about this red cell distribution width. In 1983, Bressman, he appreciated the significance of RDW in the diagnosis of anemia, and he published a very beautiful manuscript in the American Journal of Pathology. But till 2 decades back, nobody took attention of this important value. And in my subsequent part of my lecture, I'll show how important this is. Now, we are all familiar with the word N-isocytosis, which is reported by the pathologist on the peripheral smear. What is this? This is basically a variation in the red cell size, and this is a very subjective terminology. Now we have an objective terminology, that is, which is the actual measure of variation, and that is RDW. Now, red cell distribution width can be expressed as coefficient of variation, which we call as RDW-CV, or as standard of deviation, that is RDW-SD. RDW-CV is very sensitive to pick up small, that is microcytes. And we know that two commonest cause of microcytic anemia in our country is iron deficiency and beta thalassemia trait. Therefore, this parameter is very useful to differentiate between the two. And it is calculated by the ratio of standard deviation of the RBC distribution curve divided by the MCV, and it is, of course, given by the cell counter automatically. The second part of RDW is the SD, that is the standard deviation. It is very sensitive for macrocytes. And we know two commonest causes of macrocytic anemia in India is one, macrocytic megaloblastic anemia, and second, which is of course not less uncommon, but aplastic anemia. Now, it is actually the width of the RBC histogram at 20% above the baseline. I'll tell you about this. Now, RDW is the important thing about this parameter is that RDW can be either normal or increased. There is no disorder for practical purpose where RDW is low. Now, using this parameter, next slide, please. Yeah. Now, this RDW simply shows what is the homogeneity of the RBC population size. In a given sample, if RDW is normal, it means the red cells are of homogeneous size. If there are large RDW is there, that means there's a wide variation within the test pool. It never says that the cells are large or small. It simply says that the cells, the red RBC pool within the given sample is either homogeneous or it is not homogeneous. Now, if you look at the right side of the slide, this is the pictorial graph of the histogram. Now, the older cells or the fragmented RBCs being smaller in size, they shift the histogram to the left, and the larger cells, especially the reticulocytes or the younger cells, they shift to the histogram towards the right side. And this is very important when we have an interpretation of the RBC histogram. Next slide. Now, we have learned in MBBS courses, even in post-graduation, the classification of anemias according to MCV, MCH, MCHC. Now, this is one classification which is based on MCV and RDW, and this is a clinically oriented classification. With this classification, you can make a provisional diagnosis of anemia at bedside without any further investigations. I'll take up this table again and again when we illustrate how useful is CBC in the bedside diagnosis of hematological diseases. Next slide, please. Now, if you summarize this classification, you can divide into three parts. Hyperproliferative disorders, which are independent of MCV, have normal RDW. This is the group 1, 3, and 5 for the previous classification. And nutritional disorders, independent of MCV, have increased heterogeneity, that is increased RDW, which corresponds to 2, 4, 6 group of the classification which I have just narrated. And what about the hemolytic disorders? They are independent of MCV. They have RDW value, which is in proportion to the severity of anemia. More anemia you have, more severe anemia, then more is the value of RDW. So all anemias can be grouped under these headings with this classification. Thank you. Next slide, please. Next slide, please. Now, what is this histogram? Basically, it is a graphical representation of the total RBCs in the given sample, where the number of cells are displayed on the x-axis and the cell size in terms of femtoliters are displayed on the x-axis. And they are created for all the three lineages, that is RBC, WBC, and platelets. Next slide. Next, please. So this is a pictorial graph of RBC histogram. Now, we know the cell counters work on Coulter principle. So all cells between 25 femtoliter to 250 femtoliter will be counted as RBCs in the cell counter. Now, this histogram has an ascending limb, a peak, and a descending limb. If we draw a perpendicular from the peak to the x-axis, it gives you the value of MCV. I have told you that RDW is basically a reflection of the RBC histogram. In fact, in clinical practice, RBC histogram and the RDW values should be read together. They are the two faces of the same coin. They are complementary to each other. Now, RDW, as we have told you, is the width of the histogram at approximately 20% above the axis. And RDW-CV is approximately 68% above the x-axis. This is the width of the, this value is the RDW-CV. As I already told you, RDW-CV is sensitive to pick up small site RBCs, and RDWSD is sensitive to pick up large, that is macrocytes. Next slide, please. Yeah, this is the normal histogram. Just remember on the right, you have what these are the blood indices is there. This is the histogram, this is the peripheral, and this is the normal histogram. Now, this we will use as a reference histogram to see what are the various abnormalities in the RBC histogram. Next slide, please. Now, I've already told you that the platelets are also counted along with RBCs in the same, but of course the aperture is different. The platelets are counted between 2 to 25 femtoliter. Now, the importance of this slide is there in clinical practice. Now, if you have large number of small microcytes or RBCs are there, or fragmented RBCs are there, they will be counted in the platelet counter. What will happen since RBCs are in million? Therefore, the platelets will be falsely elevated. Contrarily, if there are large platelet aggregates are there, platelets are large or in clumps, they will be counted in the RBC histogram. But since RBCs are in million, therefore it will not affect the RBC count as so much, but the platelet count will be falsely depressed. And it's very important. So whenever you encounter some very small RBCs or fragmented RBCs or large platelets, then the platelet count will be either spuriously will be elevated or depressed respectively. Next slide, please. Next slide. Now, this is the pictorial graph of the platelet histogram. Again, I've told you there's a lower discriminator and upper discriminator. All cells between 2 to 25 femtometer are counted as platelets. Again, it has ascending limb, descending limb, and the peak. Now, this is that at 12 femtoliter, there's a fixed discriminator. All cells which are to the right of this discriminator are the large platelets, which is reflected as PLCR on the printout. If you go through the printout of the cell counter, there's under the platelet parameter, you see the word that is a PLCR. This is the actually, if this is raised, it means there are presence of large platelets. So simply looking at the platelet histogram and looking at PLCR, you can say, yes, there are large number of platelets, and therefore, even if patient has on counter machine, the platelet count is 90,000, but if you examine the peripheral smear and include these large platelets, the platelet count would be somewhere between 1.25 to 1.4 lakhs. So it's very important to recognize the right part of the platelet histogram, which is to the right of the fixed discriminator at 12 femtoliter. Next slide, please. Now, this is obvious. Many times you see this type of platelet histogram in the cell counter. You know that there is no descending limb is not coming to the baseline. Now, when this occurs, it means either there is what you call EDT-induced platelet agglutination, giant platelets are there, or platelet clumps are there. So, whenever you encounter a platelet histogram where the descending limb does not touch the baseline, think of these possibilities. Next slide, please. And this is a histogram which you very often you see, especially when there's a dengue epidemic or mini epidemic. There are practically no platelets are there, and you just have these small lines in the histogram. These are basically the background noise of the machine and not the platelet count. So this is a typical histogram of marked thrombocytopenia. Now, next slide, please. Now, coming to the third histogram, that is the WBC histogram. Now, WBCs are actually counted in the different counter because after the lysis of RBCs, and they are counted between the lower discriminator at around 10 femtoliter to 300 femtoliter. Now, among the WBCs, the lymphocytes being the smaller, they occupy the left side of the WBC histogram. And the neutrophils being the largest cells, they occupy the right side. And in between the two, that is between the T1 and T2 discriminator, you find eosinophils, basophils, and the monocytes. Next slide, please. Now, this is a typical WBC histogram which you see in a patient of CML. You have all the precursors, myelocytes, promyelocytes, and larger neutrophils. So you have a large dome-shaped curve, but it is, and there is not touching the baseline. because of the very high count. Now, often you see patients who have marked leukocytosis, and many of these patients have splenomegaly. At times, especially where you do not have much facilities in the rural areas, with this histogram, you can differentiate between CLL and CML, because in CML, you have a typical picture like this. Next slide, please. And what will happen in CML? In CLL, you'll have only a big, large neutrophil lymphocyte peak, and there will be no neutrophil peak. So simply looking at WBC histogram, when a patient who has marked leukocytosis, has splenomegaly, and you want to differentiate between, without looking at the peripheral smear, you can differentiate CML from CLL looking at the WBC histogram. Now, this is again a WBC histogram in a case who have reactive leukocytosis. You find broad and prominent neutrophil peak. Next slide. Now, with this basic understanding of the RDW parameter and the various histograms, let us come to the interpretation of CBC report in clinical practice. Next slide, please. Now, this is a CBC report of a 20-year-old primary gravida. If you can see, hemoglobin is normal, but MCV is very less, 58. MCHC is low. Now, look at the TRBC, it is 6.55. Now, if you see these three parameters, TRBC, hemoglobin, and MCV, all these three are discordant to each other. They do not match to each other. At the same time, you see the RDW is normal. That is, the population of RBC is uniform. Now, when you have a CBC report like this in the patient who have these three parameters which are discordant to each other and a normal RDW, you think in terms of thalassemia trait, of course, and which you can confirm the uniform microcytosis on peripheral smear. And of course, the diagnosis is clinched by doing HPLC, where the hemoglobin A2 is more than 3%. Next slide, please. So if you go back to the classification, which was based on MCV and RDW, now you can see that the MCV was low in this patient, RDW was normal. Therefore, this is a patient of thalassemia trait. The other important cause of this group is anemia of chronic disease. Anemia of chronic disease is usually MCV is normal or RDW normal, but in later stages, because of functional iron deficiency, MCV can be low with normal RDW. Next slide, please. Now, this is a CBC report of a 50-year-old man who had marked anemia, hemoglobin 6.8. You can see the MCV, MCH, MCHC. There's a microcytic hyperchromic indices is there. Look at the RBC histogram. It is peaking to the left. MCV is very low, that is 53. Now look at the RDW, is high, suggesting that there's an anisocytosis, that is the RBCs are heterogeneous in nature. Look at the WBC and the platelet, they are unremarkable. So this is an example of macrocytic anemia with normal RDW. And if we go back, please, next slide, please. So if we go to this classification, MCV is low, RDW is high, and the commonest cause in our country is iron deficiency anemia. And in this patient, if you see, you must have seen that platelet was beyond 6.55 lakhs. Now, if you have an elderly person with iron deficiency anemia and reactive thrombocytosis, always think of some source of blood loss that is accounting for anemia. The other causes in this group include the RBC fragmentation syndromes, thalassemia intermedia, G6 fatty deficiency, or hemoglobinopathy H. Next slide, please. Now, anemia of chronic disease or chronic infection. If you go look at this parameter, except for hemoglobin, hematocrit, and TRBC, all other indices are within the normal. It resembles actually the normal histogram which we had seen earlier in the earlier one of the earlier slides. So this type of picture where there is anemia and histogram is normal, all other indices are normal, is anemia of chronic disease or chronic inflammation. And similar picture can also be seen in patients who have acute blood loss. Next slide, please. So this patient who had basically what I've shown is the MCV low, and this is there. Next slide, please. Now, this is the CBC of a young male who presented with bile jaundice, moderate anemia 8.2, MCV is quite high, 113, and you can see the RDW-SD is quite high. And the RBC histogram has shifted, it is very broad, it has shifted to the right, and you can see a big population of RBCs between 100 to 200 femtoliter. So this is a classical example of macrocytic anemia with high RDW. Next slide, please. So RDW is high, MCV is high, and the commonest cause in the country is megaloblastic anemia that is due to B12 or folate deficiency. Of course, there are other causes like autoimmune hemolytic disease, liver disease, cold agglutinin disease, and in alcoholism. Next slide, please. Now, this is a histogram CBC report of a 12-year-old boy who had purpurea, marked anemia, hemoglobin 6.7. He was suffering with high-grade fever. If you see the platelets are low, WBC is low, there is a pancytopenia. RBC, if you look at the RBC histogram, it is skewed to the right. Look at the WBC histogram, you find a lot of lymphocytes are there, practically no neutrophils are there. Look at the haphazard platelet histogram, the slope is not touching the baseline. So this is, and the RDW is normal. So this is a case of macrocytic anemia with normal RDW. Next slide, please. And if you recollect this classification, that is the fifth group, MCV is high, RDW, and the commonest cause in a country is aplastic anemia. Of course, other cause could be myelodysplastic syndrome. Next slide, please. Now, sickle cell anemia, what you see is the RBC hemoglobin, the hematocrit are low, MCV is normal, and RDW is high. You can see the shift of the histogram towards the light side. And of course, these patients are diagnosed on electrophoresis by HPLC. Next slide, please. And so there, what you see is MCV is normal, RDW is high, and of course, sickle cell disease is common now, is being recognized in many parts of the country, besides the tribal areas and in the south in Maharashtra and eastern coast of India. Next slide, please. Now, if you just look at the blood indices, it appears MCV is normal, high normal, that is normocytic anemia, hemoglobin 7.6, RDW is increased. So if you just look at this parameter, your diagnosis would be normocytic anemia with increased RDW. But actually look at the histogram. Here the MCV is 99, but not here. Look at the histogram. It is widened both towards the right side as well as towards the left side. That means there are microcytes are there are macrocytes are there. Only looking at the histogram, you can make a diagnosis of dimorphic anemia. By this parameter, you cannot make a diagnosis of dimorphic anemia. And the commonest cause in the country is combined iron deficiency or B12 or folic acid deficiencies. Of course, other causes could be blood transfusion. Usually in the blood transfusion, you have a bimodal or there is a small second peak towards the normocytic range, or other could be myelodysplastic or sideroblastic anemias. Next slide, please. So dimorphic anemia, now if you go that by the numericals, MCV was normal, but actually if you see in the RBC histogram, it is quite wide, and it is wide towards both the left and the right side. And dimorphic anemia falls in this category number 4. Next slide, please. Now, this is a CBC report of a 55-year-old male who presented with mild macrocytosis. Now, look at the very low TRBCs. Here it is 2.24. Hematocrit is very less, 22, and very high MCH and MCH. Now, what has happened in here? Now, if you look at the RBC histogram, look at this part where this arrow is there. Now, this is extended. This is a plateau which is towards the right side of the histogram. This occurs because when there is an agglutination of the red cells. Now, when the red cells are agglutinated, what happens? Instead of 20 red cells, only one is the agglutinated mass is counted as 1. And that's why we have a low TRBC and hematocrit. And because it is all because of the derived equation, so you have MCH and MCHC. The same you can confirm here on the histogram. If you have a histogram like this and a picture of blood indices like this, where TRBC and hematocrit low, high MCH, think of cold agglutinin disease. Next slide. Now, this is a CBC report where you have the WBC counts are nearly 17,000. Look at the WBC histogram. This is the mid-population size, mid-sized population, that is the eosinophils, eosinophil monocytes is nearly 50%, nearly 50%. Now, if you examine the peripheral smear, you will see that it was a case of eosinophilia. So simply eosinophilia, you can, without the differential, you can see on the histogram of the WBC and make a diagnosis of eosinophilia. Next slide, please. Now, this is a CBC report of a young male. You can see mild leukocytosis there. Now, WBC, just look at the WBC histogram. You have all the three, two peaks are there and two troughs are there, trimodal. The middle population is again 30%. What you see is large number of monocytes on peripheral smear, and this is because monocytosis occurs in chronic inflammatory disorders, and the most common cause in our country is, one of the causes is fibrocavitary tuberculosis. Next slide, please. This is a CBC report of a patient who had pneumonia. Counts over, there's a brisk reticulocytosis. You can see large peak of neutrophils is there. This is what you call the neutrophil leukocytosis. And because patient has anemia, the WBC histogram has shifted to the left. And this is a case, what you looking at this, you can say it is a neutrophilic leukocytosis in the patient who had marked leukocytosis, probably because of some infection. Thank you. Next slide, please. Next slide, please. Yeah, this is a CBC report of a 50-year-old man who had massive splenomegaly. Now, look at the WBC, it is more than 143,000. Anemia, of course, normocytic anemia, platelets are normal. Both the what you call the RBCs and the platelet histogram are unremarkable. Look at this platelet WBC histogram. There is a single broad asymmetrical curve, and this is because I've told you, because all the precursors of the myeloid series are there. Because of the large number, the descending limb is not touching the baseline, and this is a typical case of CML. So looking at, if the same patient had lymphocytic peak here and no neutrophil, then we would have thought of CLL. Next slide, please. So this is a case of CLL again. Marked leukocytosis is there. You can see only one peak in the WBC histogram. That is this is the lymphocyte peak, and there is absolutely no neutrophils is there. Platelets, of course, are slight. There is mild thrombocytopenia. On peripheral smear, you can see the smudge cells, which are characteristic of CLL, and of course confirmed by the molecular testing. Next slide, please. Now, very often we see this such type of patients, young patients coming with bleeding disorder, very platelet count, not reported by the cell counter. Look at the histogram. Practically, there is WBC platelet histogram. There is no line. This is the line because of the background noise of the machine. Both these histograms are unremarkable, and this is what we call ITP. As very often you see in the dengue patients who come with very marked thrombocytopenia. What you see is the type of platelet histogram. Practically, there is no line, histogram is there, and only a slight undulating line is seen, which is because of the machine. Next slide, please. Now, this is a CBC report of an elderly person who had bluish discoloration of toes. You look at the platelet count, more than 11 lakhs is there. There is patient has mild anemia. Now, if you look at the MVP here, because again, these are the parameters which are given in the plate printouts, MVP is normal. Now, if you have reactive thrombocytosis, the MVP would be large because there would, and PLCR I have told you would be large because there would be presence of large platelets. So if you have marked thrombocytopenia, marked thrombocytosis is there, MVP is normal, PLCR is normal, then you think in terms of essential thrombocytosis. And in this patient, the JAK2 mutation was positive, which is usually seen in 50 to 60% of patients with essential thrombocytosis. Next slide, please. Now, coming to two commonest cause of anemia, nutritional anemia in a cover, iron deficiency and megaloblastic anemia. Now, what is the status of the RBC histogram and the peripheral smear and the indices in early iron deficiency? Anemia is not set in. Here, if you can look the TRBC, hemoglobin, hematocrit are normal. MCV is normal. Only parameter which is slightly deranged is RDW. Look at this histogram. Now it has slightly widened towards the left side. If you look at the parameter, you cannot make out much difference. But only looking at the histogram, looking at the RDW, well, all other RBC indices are normal. This is the stage of early iron deficiency where anemia has not set in. So you can pick up early iron deficiency state without going for investigation like ferritin, simply looking at the RBC indices and correlating with the RBC histogram. Next slide, please. No, there's one more slide before this. Okay, so probably the slide is misplaced there. Next slide, please. So now when the iron deficiency, full-blown iron deficiency anemia sets in, we all know that all the indices are depressed. The RBC histogram shifts towards the left side, and you can see a lot of pallor and the small microcytic with marked pallor RBCs. Because at this point, what we will see is this diagnosis when the iron deficiency anemia is set in is very obvious to everybody. The importance for clinicians is for the PG students is to pick up early iron deficiency state where the hemoglobin remains normal. Now, once you start treating this iron deficiency, you give parenteral FCM injection, and let's see how the recovery pattern occurs. Now, the normal recovery pattern, what you will see is like this. Now, this was the patient with the iron deficiency anemia. This is the normal histogram. Now, what has happened? Now, when you have given iron supplementation, there is accelerated erythropoiesis and RBCs are produced which are normocytic. And therefore, these are the RBCs which are within the normocytic range. This is what we call normocytic recovery from iron deficiency anemia, or what we call physiological recovery. Now, if you look, the hemoglobin will improve. RDW now it has more widened, therefore RDW will not decrease. In fact, it will become more. MCV will still not be normal, but what you can see is that the addition of this group of population, which is in the normocytic. This is the normal physiological response to parenteral iron therapy. Next slide, please. Now, as compared to the previous, now look at this. This is bimodal. Now, here the RBCs have been added, but it is added to the macrocytic range. Now, this population of RBCs has almost MCV up to 117. So this type of response, if you see after treating iron deficiency anemia, it means there is an unmasking of megaloblastic anemia. That is unmasking of B12 or folic acid deficiency. We know that multinutrient deficiency is very common in our country. When we treated this patient, we started with iron supplementation. But because of accelerated erythropoiesis, folic acid B12 was utilized. And since they were at the edge of the storage capacity, what happened? There was unmasking of macrocytic anemia. So this type of response which you see on histogram is what you call the macrocytic response or pathological response. Now, the bottom line is whenever at many times you see patients of iron deficiency, you treat with parenteral iron, they become all right. After 4 to 6 weeks, the hemoglobin touches normal. But after 3 months, they come back again. Doctor Sahab, mera to hemoglobin वापस कम हो गया. And you are at a loss. Why it has happened? Why was this iron was not effective? Was there continued iron loss? One very important thing I told you in a country is multiple nutritional deficiency state in Indian population. So what has happened? After 3 months, the folate and the B12 storage are depleted because of accelerated erythropoiesis, and we had such type of response. This you have to differentiate from refractory iron deficiency. Many times what these patients are investigated for, and these investigations are quite expensive one, for refractory iron deficiency. Before thinking of refractory iron deficiency, please think in terms of multiple nutritional deficiency. You have treated one, but you have unmasked the deficiency of another nutrient, and that is the this type of histogram. Only by looking at the RBC histogram, you can make a diagnosis like this. No other parameter will give you a diagnosis like this. Next slide, please. So to summarize, for iron deficiency, you have early iron deficiency where you have advanced iron deficiency, which is clearly visible to everybody, even anybody can diagnose, then the recovery pattern, which is normocytic or could be a macrocytic. Where there is a macrocytic, this is a pathological response. It means there is a deficiency of B12 or folic acid, which has to be supplemented in order for the hemoglobin to recover back to its normal level. Next slide, please. Now, like in iron deficiency, you can pick up early megaloblastic anemia, where hemoglobin is relatively all are good. RDW is increased, and now the histogram has shifted. Unlike iron deficiency, now it has shifted, widened towards the right side. That is, macrocytes have added. Now, at this stage, it's very difficult, even from the peripheral smear, to make a diagnosis of early megaloblastic anemia. But when it advances, the diagnosis is very obvious. MC is quite high. You can see hyper-segmented neutrophils in the peripheral smear. At this point, anybody can make a diagnosis of megaloblastic anemia. But the most important thing for clinicians and students is to recognize early megaloblastic anemia, where other parameters have not deteriorated so badly, and you can simply looking at the histogram and the RD value. Next slide, please. So like in iron deficiency, when you treat these patients with supplement B12 or folate deficiency, then you can have recovery again, which could be a microcytic normocytic recovery. Here now, the cells which have been added are within the normocytic range. But if you see the lower cartoon, here the cells which have been added are in the microcytic range. So this is a physiological recovery. This is a pathological recovery that is microcytic. That means there is an unmasking of iron deficiency anemia. Like in iron deficiency, where you had unmasking of B12 or folate, here you had unmasking of iron deficiency. So this is a very common situation in our country when you treat these patients with appropriate supplementation, and after few weeks and months, they again come up with anemia. And this is because of deficiency, which has been unmasked because of the supplementation of the primary nutrient. Next slide, please. So this cartoon summarizes how the histogram varies from early megaloblastic to the full-blown megaloblastic anemia, and the recovery, which could be a normocytic, normal recovery, or a microcytic or pathological recovery, which suggests that there is a unmasking of iron deficiency state. Next slide, please. Now, red cell fragmentation is a syndrome you commonly seen. Of course, it's usually not recognized unless and until you look at the histogram. We know what are the common causes of red cell fragmentation. Commonest is megaloblastic anemia, malfunctioning of cardiac processes, sickle cell, TTP, HUS, DIC, burns, metastatic tumor, and so on. Now, if you look at the RBC histogram, if you have a plateau towards the left side here, you know the MCV is normal, RDW is increased because of this plateau. Now, the presence of this plateau to the left of RBC, that means there is the presence of small RBCs, that is fragmented RBCs. And this is the only way a clinician can pick up red cell fragmentation syndrome in these conditions if you look at the. And of course, that can be confirmed on peripheral smear when you see the fragmented RBCs. There is no other way a clinician can make a diagnosis of red cell fragmentation other than looking at the histogram and confirming with peripheral smear. Next slide, please. Now, this is a common, I've told you, megaloblastic anemia. If you have a histogram like this, of course, all compatible with diagnosis of megaloblastic. And what you see, the skewed plateau towards the left of the RBC histogram, it suggests fragmented or small RBCs, that which you can confirm on seeing the peripheral smear. Next slide, please. Now, coming to another autoimmune hemolytic anemia, what you see in this histogram. Now, unlike megaloblastic, also the megaloblastic anemia, the histogram shifts towards the right. But there is not so much shifting. It's because autoimmune hemolytic anemia produces brisk reticulocytosis. It's one of the example of stress isopoiesis, where the reticulocytes, the immature reticulocyte fraction rises to 40, 60, 70%. So unlike megaloblastic anemia, in autoimmune hemolytic anemia, of course, the MCV is high, RDW is high, but the histogram has shifted drastically towards the right side. And of course, you confirm on seeing the spherocytes on peripheral smear, go for the Coombs test, which is positive. Next slide, please. Now, when you treat these patients of hemolytic anemia, unlike megaloblastic, whenever you treat megaloblastic, what I've told you, that is a bimodal histogram is there. But here in the hemolytic group of disorders, what happens? The RDW is proportional to the severity of anemia. As the hemoglobin improves, the RDW shortens, the histogram starts going towards the normal side. So finally, what happens when the patient is fully treated? The abnormal histogram has merged with the normal histogram, and since the hemoglobin has stabilized and the RDW returns to its normal level. So when you look at the histogram serially, patient's histogram with a normal histogram, now with treatment is merging with a normal histogram, and there is unimodal histogram, not bimodal, as in case of megaloblastic anemia. You can make a diagnosis of autoimmune hemolytic anemia, of course, which can be confirmed by other tests. So looking simply at the RDW value, looking at the configuration of RBC histogram, without any other test, you can make a quick provisional diagnosis of autoimmune hemolytic anemia at bedside. Next slide, please. Now, I've already talked about the cold agglutinin disease. Well, the large number of RBCs have agglutinated together, have formed a clump. So what has happened? Now you have a skewed diagram here on the plateau toward the right side. Now, because of this, the RBC count and the hematocrit is low, MCH, MCHC are high. Now, only if you look at this histogram, you can look at the MCVT is 124. It should be somewhere here, but here the MCV should be around here. So when the histogram does not match with the MCV value, you have a skewed, then another bimodal plateau towards the right, and even the RDW is quite widened because now it has come to here. You think in terms of agglutination of RBC, that cold agglutinin disease. So without going for further tests, you can again make a provisional diagnosis looking at this configuration of the histogram, looking at these blood RBC indices, and of course confirming on peripheral smear. Next slide, please. So I think this is my last slide. Now, how we often see patients who have uncontrolled diabetes, there is hyperglycemia is there. Now, hyperglycemia will cause osmotic changes in RBCs, and the RBCs will swell up, the MCV will increase, and there would be a shift of the RBC histogram. The moment you control the blood sugar level, what will happen? The swelling of the RBCs will go away, the histogram will return to normal. So whenever you have a patient or who has uncontrolled diabetes, blood sugar around 300, 400, 500, please do not interpret immediately the MCV value. It will be falsely elevated. Once the hyperglycemia has settled down, osmolality of the blood has settled down, and then you again go for the CBC, you'll find the MCV returns to normal. So that is very important clinical tip for PGs. Do not rush for CBC in patients who have high sugar immediately and making a diagnosis based on falsely elevated MCV. Next slide, please. So, my dear friends, I just want to say that a famous saying by Jackson, I do not believe you can do today's job with yesterday methods. So yesterday's technology will not do anything. And please, and you'll be out of the business. And if you want to remain in the business, you have to use the best technology. So I've shown you that even at the rural and district and sub-district level, the laboratories and the hospitals are giving you the actual printout of the cell counters. Of course, unfortunately, big hospitals in metro cities, big cities and towns are just giving a typed report. Only few numerical parameters are there in the typed report. They do not give the printout. I think this is my request to all the PGs. So whenever you are editing a patient who has immunological disease, please request your laboratory personnel or the pathologist to give you the actual printout of the cell counter and not the typed report. Because with the typed report, you miss large number of information. Now, with the current technology nowadays, we have nearly 58 numerical parameters. Of course, many of these parameters are of research value only. They still are not in clinical practice. But it's very important that we should interpret CBC not on a report which is given to as a typed report, but on the actual printout from the cell counter, look at the basic things like RDW, the histogram configuration, and of course the other histogram like WBC, which can give you a lot of information, and you can make a quick diagnosis bedside without any other aid. Next slide, please. And just remember, technology has helped us to have very precise reports, and large number of parameters are there. So many of the, of course, I'll be next Tuesday, I'll be talking on some parameters which give you what is happening in the bone marrow. Now, these parameters are derived only from the peripheral blood, but they give you insight into what is happening in the bone marrow. But this technology is useful only if you are an intelligent master, and only if you are aware of the various parameters and graphs and histograms which are available on CT, because the eyes can only see what the brain knows. Next slide, please. And so this is just, please do not remain like this old person. His son in America had gifted him computer and asked him to bring mouse, and he brought a dead mouse. So it is my desire to all the PG students who are in this today link, that they please should have a proper interpretation of CBC and then make a good diagnosis bedside. And it's very important, and this is a very important clinical tip. And bedside diagnosis with CBC, I think, with best of technology, you can make a diagnosis within few minutes of obtaining the RBC printout. Thank you very much for your kind listening. And if there are any questions, I'll be most welcome to answer them. Dr. Amit? Yeah.
Thank you, sir, for a wonderful lecture. That was really the ABC of CBC, and a wonderful table that you explained in a nice way of different parameters, classification based on the MCV and RDW. Sir, you were highlighting on the issue of uncontrolled diabetes and the assessment of CBC. So, is there any issue of assessing the CBC in a sick patient, suppose like CKD patient coming in heart failure, means LV failure? We routinely prescribe CBC. So, would you comment on this critical patient?
Like will
it be appropriate to interpret the ABC at this point of time?
Yes. The CBC, no, like if you talk about a critical patient with CKD, no, you just look at of course, the histogram, the peripheral smear, because many of these patients are what you call anemic. They have microcytosis because they have functional iron deficiency. And you just look at the peripheral smear, you will find the blood cells. If you find blood cells in the peripheral smear, it is diagnostic of CKD. Actually, so for students, it's very important that what they see on the microcytic anemia is there because functional iron deficiency. I'll go into some other parameters next Tuesday where I'll talk about reticulocyte hemoglobin equivalent and so on. It will be more clear how these parameters have changed the treatment of CKD and heart failure. So these are very small parameters which are available on CB, of course, on more sophisticated equipment, cell counters, but they give you an insight in how to treat them, how to handle patients who are critically ill, have anemia of chronic disease, have anemia of inflammation, and they have to be dealt. And I've shown you in one of the slides, the histogram resembles exactly the normal. All the indices are normal in the earlier stages. Only the anemia is set in, hematocrit, and the TRBC is low. So at this point, it is very important to differentiate, yes, this is the anemia of chronic disease or chronic inflammation or anemia of endocrinopathies. So the early stages, you can simply look at the indices, try to correlate with the RBC histogram, and you can pick up very early when there only subtle changes have occurred in the indices.
There's again one question in chat box. They want to clarify between RDW-CV and RDW-SD.
So RDW-CV is, I have told you, it is more sensitive to pick up microcytes, small RBCs. Therefore, it is a very useful test to differentiate between two commonest causes of microcytic anemia in a country. Iron deficiency anemia, of course, is one of the commonest cause worldwide, and beta thalassemia trait. RDW-SD, that is the standard deviation, is most sensitive to pick up large cells, macrocytes. And here in India, megaloblastic B12 folic acid deficiency is very common. So these are the patients. And then you see always, as a hematologist, we see good number of patients with aplastic anemia who have microcytosis, but RDW is normal. So RDW-SD can pick up, differentiate between megaloblastic, they are presenting as pancytopenia, and aplastic anemia per se, which is presenting as pancytopenia. Because both these conditions can present, megaloblastic can present as pancytopenia, and for a PG student with CBC cell counter only and the histogram, you can make a diagnosis, yes, this is pancytopenia because of megaloblastic, and this pancytopenia is because of aplastic anemia. Of course, the more in the definitive investigations are always warranted before you start a treatment. I think, am I clear?
Yes, sir.
Yes, sir, you are clear. Now, Dr. Sanjay, chest. Dr. Sanjay, are you here?
Yes, sir.
Yes, sir. Now, tell something and give thanks to everybody.
Yeah, definitely, sir. Very nice lecture, sir. My professor of pathology, when I was a third year student, used to say that blood is the mirror of the body. And really, as you explained, that even just by seeing the CBC and interpreting it nicely, we can jolly well diagnose a lot of conditions. Not just now, just you told us that pancytopenia along with the RDW can give you a clue of what type of disease it can be. So really, it is a very wonderful lecture, and we learned a lot of things from you. And really, it is a good advice to the big hospitals that they should not only give the printout, so typed report, but a printout is also important to see the histograms and to make the things more clear. So very wonderful lecture, sir. We also learned a lot of things, and really, I am thankful to you, and I'm also thankful to the Dean, Dr. Kamlesh Tiwari, sir, for conceiving such a nice idea of a short certificate course. So we have not enrolled in any short certificate course, but we are listening all courses, all lectures of different courses, and we are also learning. So it is really a matter of great learning, Dr. Kamlesh Tiwari, sir. Many thanks to you for conceiving the idea. Thanks are also due to our president, Dr. Paul, and the dean-elect, Dr. Girish Mathur, sir, also for making the things easy for all of us to learn. So, and it is really a wonderful thing that most of the PGA students are learning here. So they must be complimented for the quest to learn more and more. So they also deserve a lot of congratulations, and I also thank them for attending the classes. Thank you, everybody.
I think
May I
I
request
should
before closing, sir?
convey my thanks to my two colleagues and my good friends, Dr. Amit and Dr. Daria. They are also part of this benign hematology course
Yes, sir.
of ICP.
Definitely, sir. Definitely, sir.
May I
Dr. Amit.
may I request to Tiwari, sir? Sir,
Yeah.
this is only suggestion. Because you are running a very good courses for the PG students, and by adding the AI in this Zoom meeting, we can keep one compendium book of all these lectures. So if you prefer that, we can do that. Whether it is in a diabetes or in CBC or in all.
No,
So
I have
we
told
can come
all
out
the
with a compendium.
I have told all the speakers that at the end of the lecture, they will provide the write-up of their subject, and that write-up will go to the press, and there will be a book on this subject.
Yes, sir.
Writer will be or author will be the master teacher of the class, and it is his name, and that will be released in Epicon next year. Thank you. Thank you very much.
Thank you so much, sir. Thank you.
Thank you, sir. Thank you for the wonderful opportunity given to us.
Thank
Thank
you.
you, sir. Thank you. Thank you all.
Bye-bye.
Bye.
Bye.
Bye bye. Thank you.